You are listening to the Live Well with Arthritis podcast, helping you to live a healthier and happier life with your arthritis. Every episode contains science-backed support, expert advice, and a deep understanding of the reality of living with arthritis. I'm your host, Emily Johnson, also known as Arthritis Foodie. I'm a best-selling author and the founder of Live Well with Arthritis. Whether you've been living with arthritis for years, or you're navigating a new diagnosis, or perhaps you have symptoms and are looking for answers, this podcast is for you. For more support, you can join the waitlist for my course, Live Well with Arthritis, on www.livewellwitharthritis.com/waitlist. That's www.livewellwitharthritis.com/waitlist. Places are limited, so the earlier you sign up, the better. Now, let's get into the episode. I'm so excited to welcome Professor Deepak Ravindran to the show. Deepak is an NHS chronic pain consultant and best-selling author of The Pain-Free Mindset. He also contributed to my second book, Eat Well with Arthritis. For over 20 years, he's been helping people manage and understand pain, bringing together trauma-informed care, lifestyle medicine, and the latest in pain science. He's set up 2 award-winning NHS services supporting nearly 1 million people with pain and long COVID, and now serves as Director for Pain and Lifestyle Medicine in Berkshire. Deepak is dedicated to changing the way we think about and live with pain. Hello, everybody. I am so excited to have Dr. Deepak Ravindran here with us today. How are you, Dr. Deepak?
Well, I'm doing absolutely fine, Emily, and thank you for having me on your podcast, and congratulations on this new venture as well with everything else that you've done. So really glad to be part of this project and being on your podcast today.
Oh, thank you so much. I really, really appreciate that. And for anybody who's listening who may not know, Dr. Deepak Ravindran contributed to my second book, Eat Well with Arthritis, and he also has his own book, which is amazing, called The Pain-Free Mindset. And we're going to be talking about this during the podcast as well. But I really want to sort of get in there, dive in to this topic because it's huge. And I know something that you obviously have been doing it for many, many years. Can we sort of start off by saying, what is pain? What does it really mean? And what are the myths around pain? If you'd like to start there.
Yeah, great start there. And as you rightly point out, this now makes it at the time of this recording in 2024, it makes it the 26th year that I've been looking after people with pain. And my journey started as an anesthetist. That was my background postgraduate qualification. So my role initially was in understanding and treating and looking after people with acute pain, when they're admitted to hospital, when they're admitted for surgeries, and immediately after surgery, when they're recovering in the hospital bed, sometimes when they come to emergency department. So that was predominantly my role until I did my fellowship sort of in chronic pain and pain, as it were, from UCL. And for the last 14 years now, I've been a secondary care consultant in the NHS, full-time, and now in the recent few months in primary care. But now for the last 14 years, I have gained that experience of looking after people with chronic pain, people in the outpatient setting, in the community setting, who have been having long-term pain for a variety of conditions, whether that's after surgery or whether that's after cancer treatment, whether that's after diabetes, and sometimes for possibly no inflammatory reason at all. And it has really blown my mind. And that's where the knowledge that I have sort of had to read up and become better at in supporting my patients is in realizing that pain is far more complex than we ever thought it to be. And we've now understood that with pain, we are all very, very good in recognizing and treating acute pain with medications or maybe some injections or even surgery. But the reality is that chronic pain cannot be treated like an extension of acute pain. You can't just give only drugs or only injections or think of a surgery for every kind of chronic pain. And especially when it comes to, for example, the inflammatory conditions like arthritis, we are now realizing that that has to be approached very differently. And that starts first by understanding now what exactly is pain and why should we be looking at chronic pain in a different light and treating it very differently from acute pain. And so that is sort of the background. And what we are now saying is that with pain, which is a sensory and emotional experience, we're now dividing it and saying there's a difference between what we call as pain and something that we are now referring to as nociception. So, for your listeners, this might be a new word, but this is the word that is referring to all the things that happen when you have an inflammation, an active inflammation going on. So, for example, an active arthritic flare or a rheumatoid arthritis flare, or even a psoriatic arthritis flare where your knee joints are swollen or your elbow or some part is swollen, and there are inflammatory chemicals being released around the joint or where it's inflamed. That inflammatory chemicals will convince and tell the information to the nerves and the receptors in that area. And the conversion of those inflammatory chemical information into electrical signals is called nociception. That's it. That is the sum
Mm.
total. That word refers to whatever's happening at the joint, which is inflamed, and it's telling that information to the nerves and that electrical signals generated. That's nociception. That's not pain. What then happens is that those signals have to travel within the nerves to the spinal cord and then to the brain. And what now we are saying with any research, whether that's acute pain or chronic pain research, the signal reaches the brain, and the brain is then going to decide based on its past experiences, based on the context, based on where you are, what you're doing, how important it is for you. And if it decides that it needs to protect you, that's when it will bring about the experience of pain. And this, in some ways, does help me explain, and maybe it will
Mhm.
help you for your listeners as well, is why sometimes when you have a flare up of your inflammatory arthritis pain or your rheumatoid pain, why does it feel less painful sometimes on some days? Why does it feel much more painful on other days? Why does sometimes it hurt when there is no sign of inflammation at all in your knee or even on your blood tests? And this helps to explain because you don't need to sometimes have an inflamed joint or active inflammation of your arthritis or anything on your blood test like your CRP, but the intensity of pain is something that's decided based on whether the brain needs to protect or not. So that's how we're saying that we're now thinking of pain as this complex phenomenon and this difference between nociception and pain. And it's important to recognize that both can be there in many people and that the pain experience is modified by other factors rather than just the chemicals at the site of your knee, because to me it opens up a wide variety of treatment options. It says that we don't have to just think about drugs and injections every time, but if we can change the factors for how the brain makes sense of the signal, then you have other treatment options for your pain. And that is, I think, a much more hopeful place to be in rather than looking for the next strong drug or injection to relieve your pain.
Absolutely. Thank you so much for sharing that, Dr. Deepak. It's just incredible because I can totally relate as well. I'm sure the listeners can as well, to different days and different things I'm doing and different pain levels based on, what I've eaten, the kind of sleep I've had, my stress levels, what's going on in my life, etc., etc. So, there are so many things that we maybe don't know about pain, but we're learning now about pain in terms of our brains and the neuroscience behind it. So thank you so much for sharing all of that. And it's absolutely fascinating. I just want to touch back on that point that you made about being hopeful that there are other ways to take care of your pain and manage your pain from day to day. And I know you touch on them in your books, The Pain-Free Mindset. I'm sure there'll be more. And it's something I definitely speak about over on Arthritis Foodie. And also in my books, Beat Arthritis Naturally and Eat Well with Arthritis. And that is finding ways to manage your pain through diet, lifestyle, and various interventions. So if you would be happy to talk through those, I'd love to jump into that as the next topic. Thank you.
Absolutely. Absolutely. And I think it's a perfect segue to that part there is we're now saying that within the broader science and hospitals and even the guidelines in the UK have now recognized that there are actually three kinds of pain, as it were. So, one kind is this thing that we call nociceptive pain, which is when you have an inflamed, for example, with arthritis, you might have an active inflammation and there are chemicals being released. Your blood test might show that the CRP or the ESR or other immune markers are raised. That kind of pain is called nociceptive pain because there's nociception actively happening. Chemicals are being released. There's another kind of pain which often is seen when people have surgery and a nerve gets cut, or there is a group of patients who might have a knee replacement for knee osteoarthritis, or they have a shoulder surgery, but the pain then continues to remain because of changes to the nerve system, either because they've been cut or they've been damaged, like in diabetes or MS or Parkinsonism. That kind of pain is called neuropathic pain because the nerves are affected. But we've now realized that for many conditions, and even in conditions like arthritis, like you said, where the inflammation may not be there as well, but the nervous system has got sensitized. For lack of a better word, I'm probably going to say the nervous system becomes overprotective. The brain
Mm.
takes on this role of wanting to protect all the time because that's what it did the first two, three times. It would just play the same loop again. So, in that situation, that kind of pain where there is no evidence of inflammation on the blood tests or on scans, but there is no evidence of nerve damage as well, yet the person is having pain because the nerves have got sensitized. That is called nociplastic pain, indicating that there's a bit of plasticity in the nerves and that is causing pain. And so this is now a common example would be conditions like pelvic pain or migraine, or even, for example, conditions like fibromyalgia, which many people with arthritis might go on to have. But these are all the typical places where there is no inflammation and no evidence of nerve damage. And this kind of nociplastic pain, we'd have to look at techniques that calm the nervous system down. One of the big factors that is responsible for sensitizing and making this nervous system overprotective is the immune system. And so, especially in conditions like autoimmune arthritis that many of your listeners might have, we know already that the immune system is starting out as being different and vulnerable. So, in this situation, it can sensitize your nervous system to become even more vulnerable. So, moderating the immune system and calming down the nervous system is the way forward in terms of managing many kinds of chronic pain, but especially nociplastic pain. So, how do we go about that? This is where all the techniques of lifestyle factors have become really important. I mean, you could say that, okay, why can't we calm the immune system down using biologics or one of those disease modifying rheumatoid drugs? And that may very well be an option for some patients where they do need it, a tweak of some of those drugs. But we know those drugs have side effects. We know that they don't work for everyone. We know that they have problems sometimes in some people, and sometimes they just aren't suitable for everyone or not right for everyone. But a powerful way of calming the immune system down is nutrition.
Mm.
A powerful way of calming the nervous system down is sleep optimization, is stress management techniques, is physical activity, is a variety of mind body techniques. And I think if we want to manage chronic pain now, we want to be able to calm the nervous and immune system down. So we need to bring these five techniques, nervous system calming down with stress regulation mechanisms, nutritional strategies, sleep strategies, physical activity strategies, mind body techniques, whether that's acupuncture or Pilates or yoga or cognitive behavioral therapy. But it's about bringing those five techniques alongside the medications or injections. And that I think is a more whole person approach. And that's what I sort of pick up in my book. And indeed, the acronym, the mindset acronym for my book, the pain free mindset, those are the 7 strategies I say that should be brought for any kind of inflammatory chronic pain management.
Thank you, Dr. Deepak. And I absolutely wholeheartedly agree with everything that you have just said. Thank you so much. I'm so glad we're on the same page, but I think we've spoken about it before, that we were writing our books at the same time, and then they came out at the same time, and we were both writing, very similar sort of things that, yes, okay, of course, medication is going to help you, and hopefully you can find something that may help. But similarly, at the same time, there are things that you can do for yourself to help the medicine do its job, but also help you to feel well and feel better in yourself every single day. The way I sort of describe it in my books is that, if you've already got this fire of inflammation inside you, and, you might be putting a little glass of water on it with some medication, but then the fire's still going, and then you add to it with, lack of sleep, high stress, alcohol, inflammatory foods, then you're not really helping those things, you're not really helping yourself. And so whereas if you bring in lots of anti-inflammatory foods, you bring in really good night's sleep, and sleep techniques to help you to get that good night's sleep, you exercise well, you take care of your mental health, all of those things will add even more water to the fire, helping that medication do its job too, and hopefully get you back to a place where you're able to manage your pain, better from day to day. So yeah, thank you for sharing all of that. And yeah, absolutely agree with all of it. And a nice segue is to sort of come back to that point of self-management. And it's something you talk about a lot in your book as well. And you have a fantastic quote of, I think it's something like over 8,000 hours of the year that you have for yourself, aside from that 1 hour that you spend, with your consultant. So I'd love to discuss a bit more and go into detail about self-management and how this has helped your patients sort of grapple and take a hold of their health and help themselves reduce their pain and get to a better state of mind and body for themselves.
I think so. It's a great point, Emily. And when I was doing the research to write the book, that was a bit of a shocking and alarming statistic, and it was a very deeply reflective statistic for me because that made me really change, in some ways, the way I used to do my consultations in a pain clinic or in the various settings that I was seeing my patients, because the data was from a few studies which eventually said if you just added up the number of times a chronic pain patient saw a nurse and maybe a physio and maybe a couple of GP appointments and a couple of other appointments with a specialist over a period of a year, they estimated that at the most an average of 5 hours is spent by the patient in front of a healthcare professional getting some advice or seeking some steps or getting some imaging or medications. The remaining 8,755 hours in a year is essentially left with the patient to figure out what to do for their pain and to try those techniques that has been suggested in those remaining 5 hours. And the real challenge is one that made me aware of how I need to be fostering and giving our patients confidence so that what they hear in those 5 hours can be implemented by them when they are not with us, and not only implemented once, but implemented in such a way that it becomes sustainable and is maintained. And it feels like something that they want to do rather than something that they're being forced to do. Because that's the ultimate thing about behavior change, is that if we try to impose something or someone or somebody is having to go out of the way to do something, whether that's a habit change or a sleep habit or a work habit or nutritional strategy, it is not going to stick. It's not going to be sustainable and maintained, and it'll drop off when they have a flare, whether that's a pain
Mm.
flare or some acute stress in the workplace or something in their personal sphere. That habit or that routine will just drop off. And what has made me aware over the last 3, 4 years, and thankfully the rest of the NHS and the UK healthcare system is gradually warming up to this, is saying that for many patients, we should possibly offer the option of health coaches. We should have people who can actually support them in the journey so that when they make some smart goals, when they say, okay, I'm going to eat like this in order to manage my arthritis, these are the ways I'm going to modify my lifestyle so that I do this at this time, I do that at that time. We want to actually have some way to create accountability so that patients feel like they are accountable to someone, whether that's a health coach, whether that's to some family member, whether that's to a buddy that they have met in a group setting. But having that kind of accountability, having that kind of peer support, having that kind of some touch base so that if they have a flare up, they can just be told by someone, hey, this is what I did the last time, or this is what you could do, A, B, C, and that helps them overcome the flare quickly. These are all the things that will make them confident that self management process that they started is something that they can sustain without saying, oh my God, I tried this for a week, but the first problem that I had, I stopped doing it, and now I'm in more pain than ever. And so back at the GP or back to the specialist. That's something as an NHS system we can't sustain. It's not possible to be there for the patient so quickly, which is why over the last 3, 4 years, ever since I've written the book as well, and I've started practicing and I bring that conversation in my clinic, I kind of say this exact thing. I say, okay, I could give you this drug or this injection, but what if it worked only 6 weeks? I can't repeat an injection for you every 6 weeks. I can't repeat it maybe even in 6 months after the pandemic with the waiting times that they have. What are you going to do? Or I could give you an injection this time, but if the injection wears off in 3 months, I can't repeat an injection for you every 3 months. It's not safe, nor is it logically or logistically feasible. What are you going to do? So I at least raise that topic in a consultation to actually say, what could you do with some confidence by yourself if the drugs or injections aren't that effective? What kind of simple change would they be ready to make or feel they can make? And that then just gives them a bit of confidence that, okay, a doctor has trusted me, has given me a confidence to try this thing, and hopefully I'm going to try it and see if it works or not. So I think that self management skills is something we need to help our patients with, realizing that it is very tricky for everyone to just get it correct straight off the bat. Every one of us will need some support, some hand holding, and we as an ecosystem of healthcare professionals need to create that ecosystem for our patients so that the self management skills we give is actually taken up by them and maintained.
Brilliant. Yeah. Thank you so much. Thank you so much for that. That was brilliant about the self-management, because I think there is that lack of self-confidence when people are diagnosed with arthritis, when they're sat with their consultants, their specialists, that feeling of overwhelm as well. It's quite a lot to get your head around as well when you're diagnosed with a chronic condition like arthritis. And, speaking from my own experience, I sort of said to myself, oh, I don't need to do anything because my consultant will deal with it, my medication will deal with it. And I kind of turned away from my arthritis, which is why the work that I do, I'm so passionate about saying to people, you live with arthritis, and living well with arthritis in the best way that you can is something that you can do for yourself. And, like you were saying about the medication, if it only lasted 6 weeks, what else can you do in that time? But also, you have to give these things time, don't you? Like diet and lifestyle changes, they aren't going to make a difference overnight. So I think it took me, maybe like 6 months, 3 to 6 months before I really started to notice a difference. But, it can often take 12 weeks to 6 months the same way for a medication to work. So you do sort of have to have a bit of faith and, test and trial and see what works for you, because everybody is different. We all have different genetics, different gut microbiomes, all of those things. So it's really important to keep those things going as best as you can. So yeah,
Absolutely. And
thank you for
I
sharing
think
that.
we need to really appreciate that part there, that this is not just about, educational status or what the prior qualifications are, Emily. I mean,
Mm,
like, even as you told about your own experience, how long it took, and the feeling of overwhelm you felt, and this is despite education and the high level of sort of awareness you have. And this is something we realize from studies, that sometimes we think, oh, maybe the people with low confidence are the ones who don't know about health or don't know about language, or maybe it's something that's a particular demographics problem. We've realized actually that you might be super confident in your domain. You could be a very, very highly educated professional, earning a lot and being absolutely the expert in your field. But when it comes to your health, you could be someone that they call as having low activation. So you just don't have the confidence in another field, and that is independent of your expertise in some other field. So we have to be very cognizant of the fact that for low activation, they need support. It's not possible to think that, oh, if somebody's highly educated, education alone is enough. We just give them the advice, they'll go ahead and do it. We actually will need to discover what the person and the patient in front of us are, how motivated, how capable, how many opportunities they are in their ecosystem to implement the suggestions or plans we give them. And if we find that they are not feeling capable or don't think they have the opportunity or the motivation, then that's where we need to be stepping up what we offer, how we offer, and support them in that strategy, whether that's eating healthy for their arthritis, whether that's going to be physical activity, or whether that's sleep.
Yeah, absolutely. Have you got any case studies that you're able to sort of share with us? Maybe one case study for this podcast, Dr. Deepak, if you're happy to do so.
Absolutely. I think I do write about a number of case studies in the book as well. But since then, I've had so many other patients who have come through. And a more typical one, which I had recently a few months ago, is that classical knee arthritis on the background of already existing rheumatoid arthritis. So, this was a lady in her late 50s who had a little bit of overweight, so her BMI was on the higher side, and her work had been impacted with pre existing low back pain, but with this now knee pain and a background of rheumatoid arthritis that was stable on some methotrexate. And she was referred to the pain clinic because there was no evidence of inflammation, and her rheumatoid arthritis was stable. But the knee pain was something, again, it was mild to moderate arthritic changes, so something that didn't require surgery or anything more. And she herself was not keen for surgery and was more keen to look and say, well, is there a medication that could solve it, or have a steroid injection and get back to work? And it was this kind of conversation that I had, a little bit of this coaching conversation, and what I call sort of open questions informed by a technique called motivational interviewing. And we were able to uncover that there were other stresses going on in her life that were impacting her ability to stick to any physical activity plan. There were challenges happening, which meant that she was eating more ultra processed and processed foods and not able to cook healthier at home. And because she felt this constant pressure at workplace, there was an added stress that was identified. And while she did want to make changes, she realized that she didn't want to be on strong codeine or tramadol like drugs. She really did not know how to move forward with it. She was an administrator working full time, but had to go off sick because of the worsening problems. And so this was where I said, well, can you work with for a few months? This is where the critical phase is required. If we are to avoid surgery, and if injections work only 6 to 8 weeks, and these other factors are not addressed, then any benefit that I give from a nerve medication or even a steroid injection isn't going to last long. And that seemed to hit home for her. And her husband, who came to the appointment with her, so she had a supportive partner, was willing to say, yes, we need to stop and do something different. We can't go on the same way that we tried to manage it for the 2 or 3 years before they were there in my clinic. And so they made this change wherein she was able to go to a manager and say, I'd like to go part time because, or rather, at least reduce hours for a brief period to manage her pain. She made the effort to then engage with a dietitian that I have to get some advice on what would be a good anti inflammatory diet plan. We worked on giving some sleep strategies initially. So the focus initially was sleep, which you want to address there. I added a little bit of a nerve medication to help with a little bit of sleep initially, but it was a clear thing that it would be a 4 to 6 week trial of the medication while she put in some of the sleep strategies and the nutritional strategies there. And that release from work gave her the opportunity to take up a physical activity plan, something that she just wanted to go to a gym and start off with some light routines with a friend of hers. And that's what she set up on. And this is what we put in place. And I said, do you need any help with it? Of course, in the NHS, I didn't have any health coaches or anything like that. Privately, I did offer her the option, but she felt that she could manage it there. And that is where she was going to work on. And when I saw her 3 months later as a part of a routine follow up, she'd not increased the amitriptyline dosage anymore. I'd said you could go up to 30, but she stayed on 10. Her sleep had definitely improved. She was able to put the diet strategies in place. But most importantly, her spirits had gone up. She was much more visibly happier. The pain was in a much better place for her to control. She could see that making those nutritional and lifestyle changes apparently made a difference. Within 4 to 6 weeks, she started to notice that she was improving, walking for longer, sleeping better, feeling happier in herself, and had started to drop a little bit of weight as well. So, overall, everything was going in the right direction. And that was where we left it. And I think I'm due to see her in another month now for a kind of 6 month checkup and see where we are. But that is the power of what's possible with simple, good, whole person approaches, which doesn't deny anything or take away anything, but it brings in this whole trauma informed approaches. You understand the stressors, you raise awareness, ensure they have the support, and give them a plan to follow with, and ensure they have the resources to implement the plan.
Thank you so much for sharing that, Deepak. And I'm so glad that the changes that you helped her to make made such a huge difference and such a huge impact on her life. And it just shows that you don't get these things happening overnight, but you have to give them time. And yeah, that's absolutely wonderful. Thank you so much for sharing that. I'm conscious that we are sort of running out of time. Is there anything you'd like to share with our listeners in terms of chronic pain management, anything we haven't covered yet on this podcast? And I also myself want to ask you, what's the one thing that you would love for people to take away today after listening to this podcast episode?
I think the biggest thing that I would want your listeners to take away is that please keep the hope. Please keep the hope that it is absolutely possible to reduce your chronic pain, sometimes become almost pain free. And this does not have to be about finding a better drug or a newer surgical technique. it's about getting the basics right. And with that, there is a huge amount of evidence now to say that doing those techniques right is the hope to regaining and overcoming their chronic pain due to arthritis. Probably a sub note on there, the other big thing that I would want to take, especially when it comes to arthritis, is now this growing acceptance that arthritis is not a wear and tear problem. How about reframing the words as wear and repair? That your joints are constantly repairing and they have the capacity to repair at any age. So, what you are having to do is maintain the hope that you provide the right environment to your joints to repair. And that is the message that I tried to bring through in my book, even in my audiobook that comes along, and the work that I'm doing with organizations like Boutros Bear, which is a sort of hybrid platform, which has got all this wrap around this health coach, the psychologist, the physiotherapist, the nutritionist, but to wrap it around recognizing that these kind of joint up integrative approaches are making a difference. And that's the hope that I would want them to keep, that there are better and more evidence ways to get rid of their pain.
Thank you so much for that. Wear and repair. That's wonderful to end on. Thank you so, so much, Dr. Deepak Ravindran, for being here today. And if you would like to find Dr. Deepak over on Instagram or on his website, would you like to share those details, Dr. Deepak?
Absolutely. So find me. I'm on all social media channels, usually as Dr. Deepak Ravindran, all in one go on Instagram, YouTube, as well as LinkedIn. Please follow my YouTube channel where I do post a lot of videos and content on a variety of topics related to pain. And if you like not reading but listening, my audiobook is also out now on all the established sort of platforms there. So yes, check me out there, connect up with me on any of these platforms, and look forward to hearing and knowing your comments. Thank you.
Thanks so, so much, Dr. Deepak, for being here today. Take care. Thank you.
Bye. Thank you, Emily.
Bye. You've been listening to the Live Well with Arthritis podcast. If you're enjoying it, please follow and leave a review. I'd really love to hear from you. To sign up to the waitlist for the Live Well with Arthritis course, head to livewellwitharthritis.com/waitlist. For any questions or to suggest topics, email us over on hello@livewellwitharthritis.com. You can follow me over on @arthritisfoodie, that's ARTHRITISFOODIE. And you can also follow Live Well with Arthritis on @livewellwitharthritis to stay tuned for the latest updates, news, podcast episodes, recipes, and a whole lot more. I'll see you there. Until next time, live well and lots of love from me to you. P.S. Before you go, I have to let you know that this podcast is presented solely for educational and entertainment purposes only. It is not intended as a substitute for the advice of your medical professional, whether that be your rheumatologist, GP, specialist, or other qualified professional. Thanks for listening, and I'll see you in the next episode.